His body is coursing with sugar. These robots, right?
Uh-huh.
Tell me what's gonna happen.
The pancreas is gonna
Well,
notice.
the blood that is going to the pancreas will be full of sugar. Pancreas will read that it's full of sugar and then the the beta and alpha cells will react appropriately. The beta cells will get their influx of sugar via a GLUT2 receptor. The GLUT2 will convert that to ATP that binds to a potassium channel that is naturally letting potassium in, but it'll block that. That blockage causes a chain reaction, a depolarization that produces calcium to come into the cell. And the calcium binds with insulin that lets the insulin via vesicle go to the surface of the beta cell and release insulin into the bloodstream. That insulin will go find target cells to cause a chain reaction, cause a reaction to store the excess glucose if it's high.
Be more specific if you're gonna say that.
Um,
You made a general statement followed by a specific statement, and you can't do that. You have to state general, or you have to state specific, one or the other.
so at the insulin into the bloodstream, is that what you're saying?
You said insulin's being released into the bloodstream and going to target cells.
Okay.
And then you said, and then they're going to store sugar.
So
But that
Okay.
was a general statement and a specific
So-
statement, and that's not okay.
okay. So insulin is released into the bloodstream. Insulin is used in the uptake of in the storage of glucose in skeletal muscle and adipose tissue. It reaches those types of cells.
So we're storing glucose in skeletal muscle. So therefore skeletal muscle is converting glucose to glycogen?
Yes. So I guess it's not necessarily always stored. You're right. It goes to skeletal muscle and maybe and stored in adipose tissue. Does that make sense? I'm trying to make sense in my brain as I talk. So the insulin causes the uptake of glucose in
Let's start there. How?
skeleton. Okay.
No, start with how.
Cool.
How is the insulin going to be?
So
It's going to cause
insulin
it to
is
go-
going to reach those target cells, and it's going to bind to a G protein, causing a
It's
second.
binding to the G protein?
It's so the lipo, the specific word that I can't remember. It's the
Ligand?
ligand of a G protein.
It's the ligand of a G protein.
Correct. Of the receptor.
Oh, okay.
That is of the receptor,
Of a receptor that is what?
a G protein.
The receptor is a G protein?
It's a G coupled receptor.
So it's a receptor. What does coupling mean?
It's
What does the word coupling mean? Lindsay is trying to help you with
That's
just
great.
hand action.
I'm trying so hard to. The way I saw it was two pieces that one couples into the other. And
So
then-
what is coupled in this case?
Insulin and the G protein.
I'm just getting really hot here, so you guys can take over anytime you want. I can keep going.
You won't need to know this in this much depth, by the way, but this is good. I just want to know what's coupled, so that you understand what the coupling is. Use the word.
So is
What's
it
the
the?
phrase?
I'm trying to define the phrase in my brain.
Somebody tell him the phrase. You just said it. So say it again.
A G protein coupled receptor.
So what's coupled?
G protein.
G proteins
And, because there has to be two things for a coupling.
and insulin.
Say it again.
G protein.
Protein coupled receptor.
So therefore, what are the two components of that?
G proteins and receptors.
Yes,
Got it.
two different things.
Got it.
What is a receptor? Mark, what's a receptor?
Lock,
Great. That receives what?
a key.
And what is the other part of this coupling?
G proteins.
G protein.
Two different things.
So the receptor the lock and key releases the G protein. Is that what you're saying?
Correct.
Correct. Okay.
They're two different things, right? So
Got
the
it.
receptor has nothing to do with the G protein. The ligand has nothing to do with the G protein. It doesn't make any contact. Where's the G
Gotcha.
protein found?
On the inside.
And where's the ligand binding
On
to
the
the
outside.
receptor?
So the insulin binds to the receptor,
Okay, good.
releasing the G protein. There's a big, huge chain of reactions that eventually binds to the GLUT4 that causes the GLUT4 to go to the outside of the cell, and
It goes to the outside of the cell?
it goes to the outside wall of the cell membrane
It goes to the
towards.
outside of the cell?
It goes to the outside of.
It becomes transmembrane.
It goes to the outside of the outside the wall of the cell membrane.
So
Like
it's on the
it-
outside of the cell?
No, I meant
It's the-
it meant. I'm trying to say it goes to
So
the
it's like still in. and
The
like
wall,
still-
to
inside,
the wall, inside
inside
the
the
wall.
cell.
Yeah.
Into it?
So
Transmembrane?
yes,
You got this.
I know. I'm just my wording is not perfect.
What
So
does transmembrane mean?
it creates a channel for
What does transmembrane mean?
Within the membrane.
within the membrane
What's that?
across the membrane.
Across the membrane. And now you're at the part where, of the detail you need to know. GLUT4s
GLUT4s.
are the transporting protein, and they are transmembrane in order to allow that to occur. Right?
Yep.
Okay? So of all of that, he's going to go on, but all of that, you needed to know that insulin binds to that receptor. That creates a cascading effect that lets the GLUT4s that are not on the cell wall, which is the whole reason why we have to have the insulin to begin with. The insulin causes those GLUT4s to become transmembrane. That allows the glucose in.
So are those GLUT4, when they're floating around, are those like non-vesicle vesicles that then become, are they, does the name GLUT4 change
No.
when it becomes
Nope, it's called a GLUT4 transporter, and they hang out near the cell membrane, but in the fluid itself. They're not attached to the cell membrane. The insulin is going to cause them to attach. And we're at the crux of the problem of diabetes at rest. Without the insulin being able to work, those GLUT4 transporters never become transmembrane. If they never are transmembrane, we never can get glucose into the cell at rest. Does that make sense?
Yes.
So a diabetic without insulin can't ever get the glucose into the cell to be used or to be stored or whatever has to happen to the glucose, which we're not quite sure yet because Dustin wasn't sure yet.
That's just type
Well, I
1.
didn't. Yeah. Couldn't
No,
explain it.
it's type 1, doesn't, why would you just say it's type 1?
I was just thinking
So-
insulin dependent.
Type 1
Wait,
means.
wait, wait.
Oh.
Why would you just say type 1? What does type 1 mean?
That they don't produce insulin.
What does type 2 mean?
They have
The receptors
the
are
receptors damaged.
resistant.
Damage to the receptor, not the insulin, right? Damage to the receptor. In both cases, what's occurring?
The
Insulin's
insulin
not getting
doesn't get to the receptor to release the G
Does
protein.
that make sense?
Yes.
So the same thing is happening in both cases. One's just a hell of a lot harder to manage because the receptor has been changed and doesn't recognize the insulin. The other one's easier to manage because all we have to do is give them insulin because they're just deficient on the insulin. Does that make sense?
Yeah.
We'll get back to that in a little bit, but the net result is still the same in that the GLUT4s don't become transmembrane, so we can't use the sugar at rest.
In type 2, is it actually damage or are they just changing the?
The receptor is not damaged,
Okay.
it's conformationally changed to no longer recognize insulin,
Okay.
which is why we call it insulin resistant. It is resistant to, the
The
receptor
lock is broke.
is resistant to insulin.
Yeah.
Yeah.
Because the receptor is resistant to insulin, it never can make that conformational change
Right.
that causes the G protein to change and release its alpha gamma subunits.
Okay, so it's not necessarily damage like something.
Correct. Now, they could have damage as
Okay.
well, environmental damage or issues, but the main issue is that it's no longer recognizing the insulin.
Like your car key, you can't turn the lock.
Could
But
you
eventually-
go over why food and lifestyle changes that receptor?
In a little bit.
Okay.
I will, in just a moment. Yes,
So the insulin itself is not being altered either?
correct. There's nothing wrong with the insulin itself. So in,
That seems weird that your receptor would be what changes in the
But the insulin, the receptor is genetic based. It's a structure that is created by our genes. And insulin is a chemical that is produced.
Right, so it seems like your lifestyle would change what you're producing rather than your genetic material.
Well, only if we would genetically change the beta cells in such a way that they would produce something different. But
Beta cells in the pancreas.
correct. But those beta cells in the pancreas are not necessarily affected by our lifestyle, meaning that the cell itself isn't necessarily affected by environmental concerns like that receptor on cell membranes is. The cells that are on our skeletal muscle, for example, are much more available to environmental impacts than those cells within those small little islets of the pancreas. So it's not so much of a change in the hormone we're creating as it is the thing that accepts the hormone. And receptors are, just in it, as a general statement, receptors are fairly
Are they like inert?
diverse in their ability to make changes. Like, for example, nicotinic receptors. When somebody first starts smoking nicotine, they get shaky at first, right? They're shaky because of how stimulated all of their skeletal muscle nicotinic receptors are. Y'all know that the neuromuscular junction, where we're about to cause contraction in our muscles, is based on nicotinic receptors, right? So they get very shaky. But over the course of time, as they smoke more and their nicotine levels in their body are very high, they're not shaky anymore. That's because so many nicotinic receptors have been engaged that we go through a down regulation of nicotinic receptors. They get less nicotinic receptors on their skeletal muscle, which makes them not have to be as active and shaky. It also means that their reaction times in various things will go down because they don't have as many nicotinic receptors to engage during those times of need. So the goods and bad, right?
So it's not their nicotinic receptors become less responsive to nicotine, it's
They
just
have less of them.
they have less of them.
Because nicotinic receptors upregulate and downregulate very quickly over the course of a window of time. That's one example, but receptors in general are highly diverse in their ability to upregulate, downregulate, or make changes based on environmental and other types of concerns that are happening within the body. So the receptor is what changes in type 2 diabetes, rather than what the actual insulin is.
And that's the insulin receptor changing, not the GLUT4.
That's correct. Nothing's wrong with the GLUT4. Everything that's wrong is related to that receptor no longer recognizing insulin. Which means a type 2 diabetic can't just be given insulin, right? Now, they can, some type 2 diabetics are also given insulin because if you pile them with enough insulin, some of those receptors are still responsive, right? But there's enough of them that aren't that they are complex, so they have to have other medications, which is where we'll get into talking about, say, metformin or other diabetic medications that are designed to try to find ways to regulate blood sugar in different ways.
Or just exercise causes a chemical
And why
reaction
exercise
change
is
to
fantastic for
release
diabetics.
GLUT4. Yeah.
That's right.
Yeah.
Right. Okay, so now I've got to go back to what I'm hung up on here, because what you said was about storage.
Okay.
And I need to know what you're talking about.
Yeah, I guess
So,
I was making sense in my brain.
so insulin is activating these glucose transporters that's bringing glucose into the cell. So now we need to talk about what cell we're talking about
Correct.
and what's happening to the glucose when it's in that cell, whatever that cell actually
So
is.
depending on the cell that we're talking about, if it's adipose tissue, the glucose is conformed and turned into glycogen and stored.
So
is that correct?
adipose stores glycogen.
Correct. Or turns glucose into glycogen?
Adipose, fat cells do that.
No. That's a no answer. So
That's not a no answer.
that's
I'm clarifying.
It turns it into fatty acids,
Great. And
cool.
stored as?
triglycerides.
Great.
Cool.
Perfect.
And if it's in
So is that the key thing for, I mean, that's the key place that glucose goes? Is that the
That's-
key place where glucose is stored, is as fat in fat cells?
I have too much, I'm trying to burn it off, and so I turn it into fat. So it's irreversible.
So is that the destiny of glucose?
No, that's the destiny of too much glucose, too much carbs. Is that right?
I don't know.
That's my understanding of it.
That's 3/4 of the Dr. Pepper.
Yeah. But if it's going to skeletal muscle, it can be converted into ATP and into energy. And then there's two ways it can do. I can't remember the rest. I've carried the group long
You're
enough.
doing
I don't
great.
know.
So I'm still,
I've seen the hours tomorrow.
thank you. I'm still a little confused.
Good, because I am too.
You've
Mom's is gonna be
you've
so
chosen to
jealous.
use fat as your example, so therefore is fat the key component of what glucose is used for?
No. Let me pull up my notes, or somebody else could talk.
So somebody needs to either help him or something to tell me what is the main focus of metabolizing sugar? And he's chosen fat.
Well, that's only one of three.
Glucose also goes in muscle cells and hepatocytes, and it's stored as glucogen. And then I'm pretty sure when there is not enough glucose in the bloodstream, the pancreas says glucagon, and then glucogen in the muscle cells is converted to glucose for muscle cells, and glucogen in hepatocytes is converted to glucose to go back in the blood.
Okay, so let's back up. Because you said that glucose is going to enter skeletal muscle and hepatocytes. What's a hepatocyte? Thank you. A liver cell. So what's happening in each of those cells? What's it doing in skeletal muscle and what's it doing in a hepatocyte?
Being stored.
In both. So we're storing our glucose in skeletal muscles.
So
What's that?
As glycogen, because it's more complex.
So skeletal muscle is a primary storage place for glucose. Go ahead.
I thought that it only stored like a limited supply inside the skeletal muscle.
So I'm still waiting.
So
Muscles did not store. Yeah, they break it into.
a short,
It's a
small amount.
short-term
Very short.
storage.
Yeah.
Okay, so let's just break it down to one cell. Skeletal muscle. What is the primary role of glucose in a skeletal muscle
To be
cell?
converted into ATP and
Okay.
used as energy.
So it's used
Correct.
there. Yes?
Yes.
Does skeletal muscle store any?
A small amount, yes,
Great, so
into
it does.
glycogen.
It does. But you're choosing to use, okay, let me ask you a completely unrelated question. What is the neurotransmitter of the sympathetic system?
Epinephrine and norepinephrine.
So I'm talking singular. What is the neurotransmitter of the sympathetic system?
Epinephrine.
I'll ask it one more time. What is the neurotransmitter? Notice I'm not saying anything plural. What is the neurotransmitter of the sympathetic system? I'll ask an easier question. What's the neurotransmitter of the parasympathetic system?
Acetylcholine.
Well, that was easy, wasn't it?
Because there's only one.
What is the neurotransmitter of the sympathetic system?
Oh, the epinephrine.
I still haven't heard the answer.
Acetylcholine.
Norepinephrine. Because in the
I said
neurons
epinephrine
of the
and
sympathetic
norepinephrine.
system, of the preganglionic neurons, what is released in what concentrations?
Norepinephrine?
Is norepinephrine and epinephrine are both of those neurotransmitters of the sympathetic system?
Yes.
Yes, they're both neurotransmitters. But I didn't let you choose two. I made you choose one. Why did I make you choose one?
One's more definitive.
Because the epinephrine's more of a hormone through the body, and the norepinephrine's more of a
Oh, there's
neurotransmitter from nerve to nerve.
Because the neurons that release norepi and epi on cells, the neurons that release those, release in concentrations of about 90% norepinephrine, 10% epinephrine.
it's bigger.
It's not bigger. It's what does epi come from?
Norepinephrine.
Norepinephrine, right? So there has to be time for norepinephrine to convert to epinephrine, and that doesn't happen in the preganglionic neurons of the sympathetic system. I mean, it does because a little bit of epinephrine is released, but hardly any. Only 10% of what's released from those neurons is epi. Most of it is norepinephrine. So when we talk about the neurotransmitter of the sympathetic system, it's norepinephrine. That's the primary neurotransmitter of the sympathetic system. What if I ask you the question, what is the primary hormone of the sympathetic system?
Epinephrine.
Epinephrine, because in the
Adrenal
in
glands.
the adrenal gland is all the time sitting there with norepinephrine producing epinephrine. And so when it's released, it releases epinephrine at a concentration of about 80% of what it's released, and norepinephrine at about 20%, give or take. So is norepinephrine a hormone?
Yes.
Yes, but if I were to say, what's the hormone of the sympathetic system, you wouldn't say norepinephrine, because it's such a small concentration in actually what is released. Does that make sense?
Yes.
Now, put that into this context. I'm asking you, what is the purpose of glucose to a skeletal muscle? What I started hearing was it's stored. But is that really the purpose of glucose in skeletal muscle? No, it's what happens to glucose in a skeletal muscle.
It's just what I could explain at the time, okay?
What's that?
It's to produce ATP.
It's used to produce ATP. That's right, because we're using it. Now, it's true that skeletal muscles store a little bit of it. But we're talking about a very small amount in comparison to what it's actually doing. So with skeletal muscles, if I ask you what's the role of glucose in a skeletal muscle, it's to produce ATP. Does that make sense?
Mm-hmm.
Okay, now let's change that. What's the role of glucose in a hepatocyte?
To be stored.
As
Glycogen.
to be stored as glycogen. Does that make sense?
Mhm.
And that's critical because the liver is the primary pantry. It's the receptacle by which we store that sugar for future use. Does that make sense? So when blood sugar skyrockets and insulin goes up, right? Then insulin is now going to cause skeletal muscles to do what with glucose?
Make ATP.
Use it to make ATP. And what's it going to cause the hepatocytes to do?
Store it.
Store it. That's right. It's going to store it as what?
Glycogen.
Now, some of that, the liver is also going to convert to amino acids and triglycerides, and VLDLs, which are going to go where? To adipose tissue, where it's going to be stored in adipose tissue. Does that make sense?
There's a reason that he doesn't need to store very much blood at the muscular cell, or
Sort of what?
uh,
Glucose.
glucose at the muscular level, because it's pretty much on a ready supply from the blood supply that's going back.
Yeah, we always have it in the blood.
Keeps
That's right.
grabbing it as it needs it.
Yes,
So
that's correct.
It just has just enough to like fire off,
Correct.
get going, and then it just starts grabbing it. going.
Yeah, so we haven't talked about energy systems, and that's not what this talk is right now, but remember that we've got other energy systems besides the use of glucose, right? So we've got the creatine system, phosphocreatine system, and we also have the fat system and protein system. So we have other energy systems that get us going. If I'm gonna go and run 40 yards, if I'm gonna sprint 40 yards, I never get to the point where I'm using glucose. My entire sprint for that entire distance of 40 yards or so is all based on the phosphocreatine system. I never got to the point where I used glucose. It takes longer for me to get to that point of using glucose, right? And if I'm doing an ultra marathon, I'm getting past the use of glucose. I'm getting all the way into using fats, right? And if I'm even longer with that, without nutrients along the way, I'll eventually get into eating my protein, my muscle protein, right? Because those are all energy sources to keep me alive. Was that your hand? Okay.
Yeah, so when your hepatocytes create and store glycogen, when they also create triglycerides and amino acids to be stored in adipose tissue, how is it moving from the liver to where your fat stores actually are in the body?
So that, as the liver produces that small amount of VLDL and triglycerides, it's moved back into the bloodstream. And as it's traveling around the bloodstream and being pushed into our extracellular system by blood pressure, as it comes into contact with fat cells, it moves through those fat cells. It can go through the membrane of fat cells and then get stored.
And then skeletal muscle has a small amount to be converted to ATP, but what about cardiac muscle cells?
all muscle cells.
Okay.
I could say, I shouldn't just say skeletal muscle, although skeletal muscle is the majority of our muscle mass, and so that's the majority of what's studied, but cardiac cells do the same thing too,
Okay.
as do smooth muscle cells. Right, because all of those muscle cells use glucose in the same way.
Okay, then what about brain tissue?
Brain tissue also, so brain tissue doesn't store it, but it uses it in the same way that skeletal muscle uses it.
Okay.
You don't need the same GLUT, it's a GLUT2, so you don't need insulin in the brain, but it's still enters the body.
Yeah, so I'm not gonna take us down a rabbit hole on that. That is correct in the sense that insulin does not cross the blood-brain barrier. So insulin's not a chemical that can cross the blood-brain barrier. And until just a few years ago, we believed that the brain did not use insulin at all. There is some studies that have come out recently that suggest maybe the brain is producing its own form of insulin, and that it does use that. And that has led to some studies on Alzheimer's, because we believe that that might have a connection as to why Alzheimer's happens. And it has led to a kind of a subset of studies being done on whether or not there's a type 3 diabetes related to insulin issues in the brain that have nothing to do with the pancreas. We aren't at any point in time being able to say that, but we are at a point where we are starting to think that that might be a direction
That's
to
interesting.
go. But that's independent.
Correct.
But what you did say is correct in that it's a different GLUT4 transporter in the brain
Doing GLUT, yeah.
that does not require pancreatic insulin,
Gotcha.
and pancreatic insulin does not cross the blood-brain barrier. Good? Okay, so hepatocytes will then store that sugar, yes, in the form of glycogen to be used later on. Sound good? Okay. So now Mark has finished his Dr. Pepper, and it's several hours later, and he hasn't eaten anything else. I mean, we're into, he's been sitting in class, and now it's, you know, it's like 7 hours later. He hasn't eaten a single thing in any of that time. What's happening?
I'm falling asleep and I'm cranky.
So his blood sugar is starting to drop,
Good, so his blood sugar's dropping.
and so that's gonna trigger the pancreas to start releasing, is it gonna release the insulin in order to start to go grab it from the fat cells?
What's it gonna do? So
Release
it's now 7 hours after he drank his Dr. Pepper, without any other nutrients or food that has gone through his mouth.
So it's gonna, the
What is it?
The pancreas is going to sense the level of blood sugar, the level of sugar in the blood, and release from alpha cells glucagon.
And what is glucagon?
Glucagon, it's
What kind of a chemical is it?
hormone.
Great, thank you.
It's a hormone that
What is a hormone, by the way?
Produced somewhere and used somewhere else.
Thank you. It's a chemical that's produced in one part of the body that is used in a different part of the body on different types of cells. Great, okay,
Yeah.
so we've got a hormone now that's...
the hormone goes from the pancreas.
Where did it come from again?
The pancreas,
I
alpha
know.
cells,
Alpha cells of,
the pancreas,
of
The islands.
islet of Langerhans.
islets of Langerhans.
Yeah.
You know what an islet is, right? What's an islet? What is an islet? A little island. Right? Like all around Hawaii, there's little islets. Right? Okay, it's an islet that is named for some yahoo who found it. The islets of Langerhans, right? So the alpha cells are in there, they release the glucagon, and
They travel to the liver, which they're via the portal veins, the blood,
thank you.
Blood.
So it's a blood-borne hormone, great.
and it's 4 times greater going to the liver, which causes the liver to react and release its stored glycogen.
And what's that called?
Let's see here. Glycogenolysis,
Which means
converting glycogen into glucose.
to break down glycogen, glycogenolysis, lysis, the breakdown glycogen of glycogen, glycogenolysis, great.
And then the increase of, and then it causes an increase in glucose in the bloodstream, which goes to cells and back to the insulin and converting it into cells and creating ATP.
Okay? What else is the liver triggered to do besides glycogenolysis?
Gluconeogenesis,
Which is what?
the creation of glucose
From?
from the components that were broken down of the breakdown of glycogen.
Good, and that's a very unique thing for the liver to be able to do. In other words, the liver is capable of creating glucose from the acids that were created in the Krebs cycle. So it can take pyruvate, and instead of keeping it as an acidic waste product, it can actually reconvert that back into glucose through a process called gluconeogenesis.
With like the lactic acid that comes from the pyruvate,
Correct.
right?
That's right. So it'll go through its cycle and create new glucose from those acids and reuse it. And that's very unique. There's an enzyme in the liver that is capable of doing that. And it's a very unique thing to the liver. We don't get that in our skeletal muscle, for example. Right? So that's another byproduct that the liver has for creating glucose. Okay? Okay. And then the glucose is available to be used, right? Now, as the glycogen forces the liver to create more glucose, right? The glycogenolysis. Then what happens? So we've created more glucose.
Now you have a higher glucose in your blood, and the pancreas recognizes it and releases more insulin,
So that we can do what?
so that we can
Use it.
in the cells
Or restore it,
or restore it.
right? It'll be restored if we didn't use it. And if we did use it, then obviously it's not going to be restored, right? So for example, if we are doing an activity, then we have, if we are doing an activity, what's happening to blood flow?
Increasing blood flow
To where?
to our skeletal muscles.
To what skeletal muscles?
The ones used.
To the active skeletal muscles. Because there's an increase in blood flow to the active skeletal muscles, there's an increase in insulin and glucose to those active muscles. So therefore, the statistics of the glucose will be used more in those skeletal muscles, and less of it will go to the liver and be stored. Does that make sense?
On the pancreas with the alpha and beta cells and everything, are those somehow related to alpha and beta receptors?
No. No, they're called alpha beta cells because they were the first and only two cells found in those islets. And they had to name them, so they just named them off of the Greek names,
Okay,
but not related to receptors at all.
so in the liver, is there any connection to alpha beta receptors in the liver?
Yes. So in a manner of speaking, so we always talk about alpha 1, alpha 2, beta 1, and beta 2, right? But what do you know? What do you remember from AMP whatever
1 heart 2 lungs.
about beta cells, about beta receptors? You learned about alpha 1, alpha 2, beta 1, beta 2, and beta 3. And where's beta 3 found primarily?
I'm gonna guess the liver. We're gonna go with the liver.
Actually, it's found in adipose more than that, but also some in the liver.
Yeah, because epi
And when
affects it.
when epinephrine is released, it'll actually work on the liver to cause the same aspects through activity, through a different set of receptors. It'll cause glycogenolysis to occur, because during a sympathetic response, we need to increase our blood sugar as well. That's independent of the pancreas. Epinephrine has that effect on the liver. Epinephrine will also break down fat cells too, through beta 3 receptors. So we do have beta receptors in the liver and adipose tissue that epinephrine works on to bypass glucagon altogether and still increase blood sugar levels.
I'm just thinking about what point the glycolysis is stimulating to cardiac cells to reverse calcium channel blockers.
In terms of, ask that question again.
Because like when you give glucagon, you can give it for calcium channel
Correct, and beta
blockers.
blocker overdoses, that's right.
That's because you're reversing that effect by stimulating your heart cells, right?
Correct.
So where,
Yeah, so you are, in that case, you're bypassing the sympathetic system and using glucagon to bypass the sympathetic system to have action within the cell, to have metabolism happening within the cell. So we have two different things that are happening simultaneously. We have glucagon that is entering cells and causing chemical reactions. We have epinephrine that is engaging receptors that is causing chemical reactions. And those chemical reactions are in some cases the same thing, just two different ways of doing it. So in the context of, I'll go two directions. In the context of a normal person in a sympathetic response, epinephrine is bypassing glucagon because it's faster, because we had a sympathetic response to get that energy we need. In the context of a beta blocker or a calcium channel blocker, we're using glucagon to bypass the epinephrine because we can't use those receptors. It's plugged. Epinephrine can't use those receptors anymore. So glucagon is entering the cell to cause those same reactions not related to those receptors. Two different chemicals leading to the same reactions, but two different methods by entering the cell. We don't release enough glucagon physiologically to bypass that sympathetic system, which is why when you give glucagon in the context of beta blockers or calcium channel blockers, what do we do in terms of dosage?
2 to 10 milligrams as opposed to 1.
Much, much higher, because we are forcing a higher than physiologic response with that glucagon to bypass the beta system, because glucagon doesn't use the beta system to get the same reaction. But we need much higher doses to make that happen, because physiologically there's never enough glucagon to make that happen. Same reaction, two different chemicals that lead to it for two different reasons. Does that make sense? So we bypass that altogether. Good? Because think about it, if we think back to physiology, in a normal person with a response, it takes a while for the alpha cells to release glucagon. It has to be in response to changes in blood flow, and then receptors that, chemical receptors that measure that blood flow have to be engaged. Then the alpha cells have to produce that glucagon. Then the glucagon has to be released into the bloodstream. Then it has to get to the liver. Then it has to signal the liver to cause that problem. And in times of stress, we don't have that much time. So epinephrine bypasses that altogether and starts the process immediately. We're using that in reverse when we're taking a beta blocker or calcium channel blocker by high doses of glucagon.
And it's the speed, which is why we don't give glucagon in anaphylactic reactions.
Yeah, now, glucagon, we're talking about energy systems. Glucagon doesn't have the ability to cause vasodilation, vasoconstriction and bronchial dilation. That's independent. So we're talking energy systems, and that's a little bit different. So glucagon would never be able to be used for that.
Because the glucagon is only working on which receptors?
It's not, it's working, it doesn't work on receptors in this case. Glucagon is brought into the cell and chemically used right there. So in this case, it's not used on receptors.
And then it's just the presence of increased sugar that has all these
Correct.
other effects
Yes.
on your body?
Yes. And then the glucagon within the cell is creating an energy system. It's changing the energy system that changes our, for example, our contractility. In the case of like a calcium channel blocker, right? We then are not able to go through the process of producing the ATP and having the calcium released from the SR and getting the contraction that we need. Now we're throwing glucagon in and bypassing that by forcing the body to produce more ATP and to pull calcium in with it as well through a different set of processes of getting that in the cell. So it's doing the same thing with energy production, but it does not lead to dilation, contraction that the epinephrine will lead to.
Is that because the glucagon, the sugar produced from glucagon being present, has a different mechanism of getting into the cell? Or would you also be able to push D50 to reverse the calcium channel blocker overdose just because it increases?
It's the way that we're getting glucagon into the cell. We wouldn't be able to push D50 and make it, because if we push the D50, the only way that the D50 can do any action on that cell is by also increasing what? insulin. So now we're trying to combine different hormones to make something happen. We need things to happen faster than that.
Because the glucose produced from a glucagon does not need insulin to enter the cell.
Correct.
Hence why it's stimulating to calcium
Correct.
in the heart.
And glucagon has its own effects all by itself also that we haven't even started to talk about. Yeah. So we are using two different chemicals, in this case glucagon and epinephrine, to bypass each other to get the same reaction.
Right, but it's not really the glucagon that's bypassing the epi, it's the sugar that's produced from glucagon.
Well, glucagon also has some effects on its own. But yes, it is also the forcing of the glycogenolysis that
What
we
are the
get.
other effects that it has?
So glucagon has its own direct effects within the cell, which I'm gonna hold off on talking about for just a minute because that'll be a different topic when we talk about that specific part of it. And to not be confused with what glucagon's doing right here, in this particular case, in the context of diabetes. Good? Okay, so our blood sugar going up and down regulates our insulin and glucagon responses. We good? Yes? Okay, before I give you a break though, when we talk about glucagon in the context of diabetic issues, right, or low blood sugar, and we're providing glucagon, everything we just said, what does it mean when you give glucagon? You know what glucagon's going to do now, so what does that mean to our patients if we give glucagon?
If they don't have enough stores, then you're just gonna waste it anyway.
Right? Glucagon can't cause you to increase blood sugar levels if they don't have the stored glucose, the glycogen, to begin with. Does that make sense?
And
Glucagon is a hormone that causes the body to create glucose, either by gluconeogenesis or glycogenolysis, right? If we don't have the glycogen to begin with, then giving glucagon can't have an effect on raising blood sugar levels.
And if you have a chronically low blood sugar in the first place, you're not going to naturally store glucose.
You'll store less, right?
So you'll have even less
because you'll be
available.
constantly using it.
Correct.
So key patients where glucagon will have very little effect as it pertains to blood sugar levels are what kind of patients?
Alcoholics.
Why alcoholics?
But they're always malnutrition.
Because it's malnourished patients, right? And alcoholics tend to be malnourished. So it's not just alcoholics, it's anybody who's malnourished. So who else is malnourished besides alcoholics?
Homeless population.
Yeah, the elderly population, transient populations, right? Some people that have eating disorders,
Liver issues, maybe?
some people that might have liver issues. Those are all areas where you have to start contemplating, is glucagon the right thing to give this particular patient? Because if they're malnourished, giving glucagon is not going to give them any benefit to raising their blood sugar levels.
Hence why it's usually a second line. If you
Yeah,
can't.
so hence the reason why we can't just say, hey, if someone is hypoglycemic, you have oral glucose to give, D50 to give, or glucagon to give. Just give one. All of them are given for that reason, but you have to think glucagon is not going to work if we don't have stored glucose, right? Oral glucose is not going to work if they've got abdominal issues and or they can't swallow. If you can't get absorption, that happens, right? D50 is going to be a problem if you've got vein issues or you can't get good access somehow.
Why can't you provide D50 rectally?
You can. D50 can go rectally as well.
Absorption rate.
The absorption rate is not nearly as good as IV. And if you do put D50 rectally, you do have a lot of vasculature in your rectum, and some of it will absorb, but it won't absorb to any level like what you'd get in an IV. But you'd expect it to be similar to oral glucose.
Could you use oral glucose rectally?
It doesn't matter, yeah, because it's just straight glucose.
Okay.
But what D50 is just glucose, right? So it doesn't matter which one you give, it's perfectly fine. Just realize that rectal blood vessels, that they will absorb some, but it hasn't been found to be as effective as oral glucose or D50. But I mean, if you have somebody that you can't get a vein on, and you can't get an IO on, and they're unresponsive and they can't swallow,
And glucagon
do a
is too much.
suppository of it, see what happens.
Why is that not in the basic scope?
It's not in the basic scope. It's just not discussed very often because it's very rarely necessary.
I'm curious what's meant
New
by
scenarios.
fatty liver, like that. I don't know if it's like a syndrome or something, but I've heard that said before. and
Yeah,
I've
fatty
never
liver
heard that.
disease?
Yeah.
So sometimes the liver is producing additional amino acids and additional problems within the liver that make it not be efficient because of the enzyme problem that's happening in the liver. We'll talk about hepatic issues all on their own this time,
Okay, so it's not
as
necessarily.
a separate, but
related.
independent of diabetes. Good? Questions so far? Okay, get up and stretch for a moment.